What's the first thing that most people want when something feels off in their health? It's testing. So it would be reasonable to think that when you have hot flashes, mood swings, hair loss, or feel like something's off with your hormones, that you would get hormone testing. But here's the thing. Hormone testing oftentimes doesn't tell us much more than what you have to share. I'm naturopathic Dr. Hussain, and this is Phase to Phase, the Hormone Health Show. If you've ever wondered, do I have a hormone imbalance and need hormone testing? Why will my doctor agree to hormone testing? And why is everyone online trying to sell me hormone testing? This episode is for you. The thing is that not all tests are created equal. Some are incredibly helpful for understanding what's going on in your health, why you're having the symptoms that you're having, and to help us guide treatment. But some not so much. First, let's start with why you might want hormone testing, or what brings people into my practice even that makes them ask the question, should I get my hormones tested? Or can we test my hormones? So I'm going to throw them into four sort of buckets. Number one. Let's say you suspect you're in perimenopause, or you actually are in perimenopause, and you're noticing symptoms like heavier bleeding, shorter menstrual cycles, hair loss, abdominal weight gain, mood changes, skin changes, hot flashes, night sweats, insomnia, a combination of those or all of those or some of those. Number two, let's say you're on hormone therapy for perimenopause or for postmenopause care because you were having some of those symptoms I just listed. And you're wondering, do I need to get my hormones tested to assess my hormone therapy treatment, or to monitor progress over time, or to sort of make a decision around whether I should continue or not? Number three, and this is the biggest reason I have patients come into my practice for hormone testing potentially, and this is cyclical symptoms. So symptoms that you're noticing in a cyclical pattern alongside your menstrual cycle. So this could be mid-cycle spotting and bloating. This could be premenstrual spotting or heavy bleeding or period pain. This could be like that combination of irritability, mood swings, feeling weepy, breast tenderness, acne, migraines, bloating, constipation before your period, like clockwork. And this could also mean more severe and debilitating symptoms, like you feel nothing like your normal self, you have no control over your mood or life. And this actually could even point us in the direction of premenstrual dysphoric disorder, or PMDD. Then the fourth bucket of symptoms is those symptoms that are intermittent, that may or may not be related to your menstrual cycle or be persistent over time, or that are new and here to stay for you. And this could include a lot of things, and things that are oftentimes online put in the bucket of like hormone imbalance, that buzzword that's going around these days. And this could be things like hair loss, brain fog, fatigue, pelvic pain, pain with intercourse, lower libido, digestive issues that sort of stay, bloating, constipation, loose stools, excess hair growth where you don't want it, so like on your face, on your back, acne, body temperature dysregulation, and a lot more. And here's a thing that not many people will tell you online, or that isn't as known as it should be. Yes, most or many or all of those symptoms can be due to hormone change. But hormone testing isn't always the answer, especially because in medicine, we rely a lot on testing and objective data. And I can highlight this with a couple of examples. So let's say you are feeling really tired, you have shortness of breath, you're losing hair, you have brittle nails, and you have restless leg syndrome. We can actually test your iron. And then if it's low, let's say your ferritin, the iron test that we typically run, is at 10. And ideally, we want you over 50. So we can actually take that 10, be like, okay, you're iron deficient. Let's supplement you for 6 to 8 weeks. And then we're going to retest it because that's going to tell us if your iron levels are coming up. And then we're also going to talk to you to see how your symptoms are. Maybe you're going to notice less hair fall. You're going to feel a little bit better depending on how fast your levels rose and how diligent you were in taking your iron, which is a big thing that people miss, right? Like they just don't take their iron. Thyroid is a good example of this too. So let's say you are someone who has those similar symptoms, actually, because iron deficiency and hypothyroidism or underactive thyroid can look very similar. Let's say we test you and now your TSH, or thyroid stimulating hormone, is high, which means that you're actually not making enough thyroid hormone. You have underactive thyroid. And now let's say we give you medication, levothyroxine, and you take it and then we retest you. Again, we're going to see what your experience in your body is. We're going to test that TSH to see that it's come down, and then we adjust our plan accordingly if it needs to be adjusted, or we carry on if you're feeling well and your TSH has normalized, right? So there's a time and place for testing, and there's some tests that work quite beautifully in that way in a linear fashion. But hormone testing doesn't always work that way. And that's what we're going to get into next. Why? So hormones naturally fluctuate, right? They're meant to fluctuate. It's not a good thing. It's not a bad thing. It is just a thing in our physiology that happens. Let's take a step back and talk about estrogen and progesterone and what they actually do in a menstrual cycle. So when you have a period, that's the beginning of your menstrual cycle, estrogen will rise fairly rapidly. And that causes, you to build your uterine lining again. It causes a lot of other things. And then it reaches this point at which it can trigger ovulation to happen, right? Like that release of the egg in the middle of the cycle. So estrogen goes up in the beginning of the cycle, and then it takes a little bit of a dip when you ovulate, and then it starts to go up again, and then it goes down again, and then you have a period. Progesterone, on the other hand, it is low, low, low at the beginning of the cycle until the midpoint of the cycle-ish when you ovulate. And then progesterone is going to rise even beyond the level of estrogen in the second half of the cycle, in the luteal phase, because that's when we make progesterone. We make it after ovulation as a result of ovulation. So let's say, and this happens all the time in my practice, especially with fertility patients, and sometimes even referred by other practitioners, they'll come in and they're like, my progesterone is low. And then I'll look at their blood work, and then I'll ask them, like, when was your period? The next period, because ovulation is what dictates when you're going to get a period. When you ovulate, you get a period around 2 weeks later. If you ovulate late, for whatever reason, let's say you were really stressed, or let's say you had an infection, or let's say you had an injury, whatever the case is. Let's say your ovulation was delayed for some freak chance for that cycle in particular, and then we tested you before you ovulated, and then you come in and you're like, my progesterone is low. My cycle is typically 30 days, but I tested this on day 20 and I still had low progesterone. Like, what's going on? Do I need progesterone? And then when we take a look, like that person actually had their period delayed by 10 days, which means that they ovulated 10 days later, right? Like that context really, really matters. And that's why like the timing of testing sometimes really matters. It's not that your progesterone is low because you're not making progesterone. Your progesterone was low because you didn't ovulate at the point we tested your progesterone. So that context matters. Now, if you're someone in perimenopause, for example, you actually are likely ovulating less and less, or not at all, especially as you approach your final period ever. So if you're testing your progesterone, it's really just telling us that you're not ovulating, which is not surprising because that's what's supposed to happen as you approach menopause. Again, it's not a bad thing. It's not a good thing. It's just a thing. It's part and parcel of the perimenopausal hormonal transition. And in perimenopause, we don't have like this beautiful, natural, linear decline in hormones. It is up and down, right? And that's why we have so many different experiences in perimenopause. Some people can have a smooth transition. Some people can have it up and down. Some people can start 10 years before. Some people only have symptoms in like the couple of years leading up to. Some people have symptoms after they hit menopause, right? Like after they stop menstruating. So there's no right or wrong way to have hormone change. What happens is that these symptoms are due to hormone change, but it's not because of a certain hormone level. And that's what I really want to drive in today. How your body responds to the change in hormones and how my body responds to a change in hormones can be vastly different. And the contributing factors here from what we know so far in science include your genetics, your epigenetics, so the environment that our genes are expressed in, your upbringing, if you had trauma earlier in life or around puberty time, if you have gone through hormonally sensitive times, if you have other mood or mental health disorders, life, chronological aging, like all of this starts to merge into one thing, and that all can influence how your body and how your brain is responding to hormone change. And I'm going to highlight this with an example of PMS. So PMS, or premenstrual syndrome, is when you have like these physical and somatic mental emotional symptoms in the lead up to your period in the luteal phase, and then they get better once you get a period. And that time is a significant time of hormone change because your body produces estrogen and progesterone, like I mentioned, after ovulation. And then as it realizes, oh, fertilization didn't happen, pregnancy didn't occur, they start to come down. That change in hormone is what you're responding to. So if we were to line up 50 individuals, and let's say these are the same age and it's 3 days before their period, we line them all up. And all of them have the same symptoms. They all have breast tenderness, they all have mood swings, they all have insomnia, they all have acne, they all have migraines and bloating. Let's say the rest of their lives look fairly similar. Their hormone levels are going to be different. And it's because we can't draw a straight line from a certain hormone level to their symptom. It is how their body is perceiving that hormone change. The flip side is also true. I could line up 50 menstruators who all have the same hormone levels, estrogen and progesterone, 3 days before their period. And they could all have vastly different experiences in their body. Some people could feel fantastic, and some people could feel like crap, and everything in between. This makes hormonal health quite frustrating for a lot of people, I understand. To me, it also makes it fascinating because I'm a nerd and I love science. But it is confusing, and I get and I understand why sometimes people can feel dismissed in their healthcare if they're not getting their hormones tested. But honestly, it's you and your experience in your body, especially from a PMS and perimenopause perspective, that matters the most. It doesn't mean that hormone testing can't be appropriate. It still can be very appropriate depending on what's happening and which hormones we're testing. But it isn't always the answer. It's not going to always tell us what you think it's going to tell us. So let's talk about when hormone testing is appropriate, because it is appropriate in many, many instances. So if your period has gone missing, I'm going to highlight like 3 things first. So if your period has gone missing and it's not because of pregnancy and it's not because of a hormonal medication or something like that, then we want to test your hormones, because it could be something called hypothalamic amenorrhea, in which case we are seeing sustained low levels of hormones. Your body's just not prioritizing reproduction in favor of survival. That's kind of a loose explanation of that. You could be in premature menopause, so like early menopause, something called primary ovarian insufficiency, right? Like we want to understand what's happening. If you've been struggling with fertility and we're doing a fertility workup, then yes, obviously hormone testing is super appropriate. If we're diagnosing a condition like PCOS, then again, hormone testing is appropriate for 2 reasons. We can actually rule things out. We do have to rule things out in that case, like things that look like PCOS, like if you have high prolactin or that lactation hormone, that can make your cycles irregular. That can also cause a little bit of the symptoms that PCOS presents with. And then we also want to do some ruling in. So let's say you aren't someone who has visible, like significant acne or hair loss or hair growth that oftentimes accompanies PCOS, then we can test your testosterone and DHEA, right? So like there's a time and a place to do hormone testing. But for most of us who are going through like these big buckets of hormone-based symptoms or even cyclical symptoms, it's not always necessary to do hormone testing. Like I said, your symptoms really matter, which means that your tracking actually really matters as well. You can throw your symptoms in your period app, and that can tell us if it's cyclical, if it's not cyclical. Either which way, we get answers, we get an idea of what's happening or what's not happening, and then we take it from there. Here's how I want you to think about hormone testing, because this is how we think about hormone testing in the healthcare world. Testing should help us answer a question that we can't otherwise. It should help rule something in, help us rule something out. It should help us guide to treatment or to monitor change over time. It should help us screen for common concerns in your age group or demographic group, whether that's like cholesterol or iron for menstruators is a big one because we lose blood all the time, blood sugar, if you have a family history of autoimmune condition of some kind, right? Like that will dictate when we do some screening tests. Screening means that we're looking proactively for things. And then it should always be considered alongside your symptoms, right? Like if you are having symptoms, if you have risk factors that are unique to you based on your past or your family history, your story, all of that matters in order to identify which tests are appropriate, how frequently we run them, and that context sometimes gets missed in short appointments in our conventional healthcare system. And that's why I really appreciate longer appointment times with patients, because we can obviously talk about all of these things regarding hormone testing, but then I can draw from different systems of their body, right? Like we're going through their whole health, and I can piece things together and really identify what testing is appropriate or not. And their experience in their body, their symptoms is what drives that, and also our treatment plan. Now, Blood testing is likely the best way to go for hormone testing at this point in time. That might change in the future. And like I said, part of growth and part of science is improving upon what we know, and that might change. But for now, blood testing really tells us everything we need to know about most of our hormones. Yes, you can still use like an ovulation predictor kit or LH strip if you're trying to identify when you're going to be ovulating for fertility purposes, for example. Pregnancy test is a urine test, obviously, and you can use that, and that is effective. But when it comes to other sex hormones, we are likely relying on blood testing because that tells us what we need to know, and it's backed by evidence. So that's going to come from your regulated healthcare provider who can do that controlled act, like your medical doctor, naturopathic doctor, nurse practitioner. There's a few tests that you can run, obviously, through stool, not hormone testing, but other testing, as well as urine. Like cortisol is a good example of that. But again, there's a time and place to run those. And I'll actually bring on a guest in the future to talk about cortisol a lot more in depth. Then there's these fancy tests out there, and my colleagues and I call them fancy tests because they're usually urine or saliva. They're quite expensive, like 3 to 10 times more expensive than blood testing. And you're not necessarily going to see a lot of regulated healthcare professionals use these because of the lack of evidence and science for them, and because we use blood work, and that is often enough. But they can be used by people who can't requisition blood work. For example, coaches in the online space are a good example of that. Sometimes it's really, truly well-intentioned to help people who are slipping through the cracks, who are finding that, these people need support with their hormonal issues and either don't have family doctors or don't have access to blood work in whatever way. So some of it is quite well-intentioned. Some of it, as we all know, comes with a profit margin. Just to give you some context, medical doctors, nurse practitioners, and naturopathic doctors, when we run blood tests, like through Life Labs, for example, in Ontario, we can't make a profit off them. They're just the tests and whatever admin costs are associated with that. That's it. And then the other piece of that is oftentimes when coaches or online influencers are selling the tests, they're also selling things to address what they're finding in those tests, right? Like, so that could be supplements, that could be protein powders, gadgets, whatever it is. So I just want you to really be a conscientious consumer, right? Like, I want you to obviously get the care that you need and deserve. Please do. Your symptoms, like I said, even if they're not showing up on blood work, can still be hormone based and hormonal, and your response to hormone change. But I also don't want you to waste your time, money, and resources on things that you don't necessarily need. So if you're considering this kind of test, I would really ask, like, what does this offer more than blood work would? Is it actually rooted in science? And does this change my treatment plan in any other way versus like doing regular blood work or just talking to my healthcare provider, right? And I think like this is where healthcare providers can step up and really maybe share their thought process, even if it's just in a couple of sentences, because I think that would be really reassuring to patients who are looking for support. And the last 2 things I want to leave you with are this. Number 1, with hormone change, your basic testing like iron, vitamin D, thyroid, and B12 still really matters because they can actually change how your body responds to hormone change and can change how you feel at baseline. So for example, if your energy levels are at 4 out of 10 and you're iron deficient, then giving you iron might not bring you to 10 out of 10, but it might bring you to 6 out of 10, which makes you that much more resilient, which may help you a little bit with your bleeding patterns, which may help you a little bit with your PMS. Same thing with vitamin D. If you're vitamin D deficient, bringing your vitamin D to normal levels might not make you feel incredible or like the best you can, but it will change your baseline just enough to make you a little bit more resilient to that hormone change and how your brain and body are perceiving hormone change. So don't poo-poo those very foundations and make sure you take your iron and vitamin D and B12 or whatever it is that you need if you're low. Number 2, in the same vein, your lifestyle, like your sleep, your stress management, your nutrition, your exercise, your self-care, your social support, your community, your work and personal life, all of those things also really will affect how you respond to hormone change. This is what we consistently see in PMS as well. Like lifestyle modification is the first line treatment for PMS. And it's because when you have those things in place, then you make better decisions in general because you're not making decisions from like this sleep deprived, stressed out place. but also your brain and your body in a completely different place to receive hormone change. You might react in a more balanced way. You might still have symptoms. You might still need additional layers of care. I'm not saying that you might not need that, but how your body perceives that may be completely different, which actually helps you in the short term and the long term. Plus, those are also the things that set you up for better aging, bones, brain, heart health, right? Like all of the things. So those things should always be addressed. And I really encourage you to take care of your body and your health and your life in that way. And then you can still layer atop that things like acupuncture, herbs, supplements, therapy, medications, etc. At the end of the day, I really want you to center your symptoms and your experience in your body, and maybe even write it down in a couple of sentences for your health provider when you go in and are experiencing these hormone-based symptoms. Ask them if hormone testing is appropriate, because it's really not just your lab numbers. It's you and your lived experience in your body that matters the most when it comes to hormone health specifically. So I thank you for listening to Phase to Phase. If you know someone who has been debating hormone testing, make sure to send them this episode. And remember, whichever phase of life you're in, you deserve answers, you deserve care, and you deserve to feel well. I'll see you next time.